So, good afternoon again. We are now starting our afternoon session. I'm very pleased to introduce you, Rosa. You already know her very well, and our two distinguished speakers, Mark Solms, and of course you know him, and Katy Bogliatto from the Belgian Society. So you already know Rosa. She's co-founder of EPD. She's a child neuropsychiatrist, and she's active in many fields. But you can also see here projected on the screen the books she has written or produced. So, Rosa, to you the floor. Come on.
A premise before starting, we started this session on depression 10 years later, and over the century of this century of psychoanalysis has given rise to a variety of models of depression. The discussion begins with Freud in Mourning and Melancholia, then Melania Klein, the exploration of Melania Klein on the depressive position has been really important, and furthermore Winnicott talked about depression, and today we have a lot of models including Echegoyen on pain and depression, and Bollas obviously. So there are many well-known models in this category, and today I will not review these models. I need more time than an hour to review all these models. I've chosen to focus mainly on neurobiology of depression, or to bring here the neurobiological point of view, because in these last 10 years, I think many discussions, a lot of discussion concerning treatment, and a lot of discussion concerning drug treatment. Drugs yes, drugs not, which ones? So, however, I'm going to talk about depression and treatment and drugs treatment, but I would like to assure you I'm not talking only about drugs, this kind of treatment. As usually, I would like to raise two questions for you. I would like you to consider these two questions. The first one is reductionism, and the second one is the treatment. If we consider the mind more complex than the neurobiology, if the complexity of the mind exceeds this of neurobiology, we are in the field of reductionism today when I speak about neurobiology. Can we be sure about this? Are sure when we talk about neurobiology, this is a sort of reductionism, considering the mind as more complex than neurobiology? So I would like to show you the point of view of the neurobiology. And second, the second question for you is, if we can consider a different point of view about the treatment, not only psychoanalysis, psychotherapy, but other treatments. So the neurobiological etiopathogenetic point of view become more important, and so we need to consider today, 10 years later we started, today we can think of the treatment of depression without thinking of neurobiology and drugs? Two questions for all of you. We start. I don't need this. Okay. The WHO, depression disorder, consider depression as a common mental disorder. Globally, this is estimated from about 5.7% of adults in their life, they suffer from depression. Women more than men, and depression can lead to suicide. in approximately about 332 million people in the world have depression. 300 million. And suicide is the third leading cause of death in young people. So this is why today we talk about neurobiology of depression and depression. If you follow this line, in 10 years we double the depression. Then about in 2015, about 10% of the population globally was affected, and now we are more than 18%. And according to the WHO, obviously, during a depressive episode, I think all of us agree with this. It's really common. I'm talking about really common topics. A person experiences a depressed mood. The feature, the core of depression is depressed mood. And at the same time, the feeling is sadness, irritability, emptiness, and they may feel loss of pleasure, loss of motivation, loss of energy. Obviously, this is the core. Obviously, we have other symptoms are also present. Poor concentrations, feelings of really excessive guilt, and concerns about the future, thoughts about dying or suicide, and so on. DSM-5 and ICD-11, just to give us the idea, 10 years before, 10 years later, but the classification is the same. Bipolar disorder, first one, cyclotimic disorder, major depressive disorder, persistent depressive disorder, and so on. It's almost the same in 10 years from DSM-5 and ICD-11. The PDM, this morning someone asked about the PDM, is the same, almost the same. The PDM second. Mood disorder, persistent depressive disorder, major depressive, cyclotimic, bipolar, and depression postpartum, maternal affective disorder. DSM-5, ICD-11, PDM, the core of depression, the classification is almost the same. Red map. Red map means maybe sometimes we can find some differences among the models. For example, PDM second, they put the depression on, or the p-axis of personality. P means personality. The PDM talks about depressive personality. But the key features inside this axis, depressive personality, the key features are always the same we find in this core of depression. But they added the key features maybe we should consider constitutional pattern, like genetic predisposition or preoccupation as central core of depression, sadness, guilt, or thought they are all the thoughts about around themselves. I'm wrong, something is wrong in me, or about the other. If I show myself to others, I'm inadequate. This is the core for, according to the PDM second, for depression. But red map again, differences, okay? DSM-5 uses the term persistent depressive disorder. In this persistent depressive disorder, the DSM-5 includes chronic depression and dysthymic disorder entities, very huge category. And above all, symptoms from chronic depression to dysthymic disorder, symptoms overlap with those of other disorder featured by persistent low mood and lack of enjoyment. persistent low mood, and the lack of enjoyment overlapping with bipolar disorder, but also in borderline personality disorder. This disorder have several common symptoms characterized by distinction of some little differences, and sometimes it's very hard to distinguish bipolar disorder from personality, from borderline personality, from mood disorder. It's not so easy to understand the distinction between all these categories. And above all, moreover, persistent mood disorders are widespread today. Another red map here, the DSM consider the mixed anxiety depressive disorder. This is a new category. This is a new category means this mixed anxiety and depressive, we don't find the core symptoms of depression, we don't find the core symptom of anxiety, we find a sort of mixed symptoms. But it's really important to distinguish this category, depression and anxiety together, from other category of depression, because this is different from bipolar disorder or mood disorder or dysthymic disorder. This is a new category. Just to give you an example of what mood disorder is, this is an illustration of manic, hypomanic, depressive mood episode in bipolar disorder. The normal mood we can consider, metaphorically speaking, we can consider normal mood, the line zero, the normality of the mood. Then we go up and down, high mood and low mood. High mood means manic episode, low mood means depressive episode, and sometimes when the high mood is not so excessive, we talk about hypomanic episode. But if you take a look at this line, okay, these people never experience a normal mood. The line go up and down in a manic or depressive episode or hypomanic episode. This is a strong difference between other emotional disorder, where young people can experience this, or morning, can experience this mood disorder. But the line is sometimes they experience a normal mood. In hypomanic, manic episode and depressive disorder, the normal mood is never, they don't experience a normal mood. And in this category, another red map is the ultra-rapid cyclers. Why the ultra-rapid cyclers are so important to us? Because the ultra-rapid cyclers, this category belongs the young people today, the addicted people. If you look there, all this is a rapid, ultra-rapid cyclers. They experience, they don't have, they have some normal interval of normal mood, but this lasts no much more than 2 days. In 2 days, the interval is 2 days. In 2 days, they change, the mood go up and down, up and down. And this is really important to us because we need to consider the higher incidence of suicide in these young people. Few words about anatomical, neurobiological, etiopathogenetic hypothesis, just a few words. Don't believe me, I will be short. Anatomical and pathophysiological basis, obviously. Post-mortem, obviously, and sometime in imaging. Okay. Reduce the volume of limbic structure, all the limbic structure. Reduction of glial cell number, above all in hippocampus. Remember this morning we talked about hippocampus and amygdala. Reduction of glial cell in hippocampus and reduction in neurogenesis and changes in cerebral fluid, okay, fluid fault. And the last one I had. Okay, I would like to show you this. hypothalamic alteration. This morning we talked about stress, trauma. So we are talking about depression, and what we find at the end, hypothalamic alteration. And obviously, the main core is dysfunction of monoaminergic neurotransmitter systems. Monoaminergic neurotransmitter system doesn't mean only serotonin, doesn't mean only dopamine. All the system of monoamine are involved. Hippocampus. This morning we talked about hippocampus. Okay, this is depression, okay, and anxiety. Maybe that involves the same circuits. Okay, hippocampus, mesolimbic system, amygdala involves emotional exertion, no? Emotion, fear, and anxiety, but at the same time, but different. The hippocampus has just three layers. So this is the first, the external part of the hippocampus. This one is the internal part, the hypothalamus, go to prefrontal cortex. That means this circuit in depression involves learning, cognition, anxiety, and the HPA axis. That means stress. Depression is not only the core that I talked about. Depression is also stress. Involves the stressful system. Red map, other neurobiological structure we need to consider, limbic structure, and the second one, this is okay, we know a lot about limbic structures. The second one, tomorrow we are going to talk about this, reward circuits. Reward circuits, so you find here nucleus accumbens, amygdala, all the area, tegmental area, insula, thalamus, a lot of reward system, reward circuits, means motivation, means energy, means salience circuits. And again, neurobiological factor of hypothalamus and anterior temporal cortex, stress, and obviously the UFA. And obviously the deficiency of neurotransmitters involved in this circuit are dopamine, serotonin, norepinephrine, and also damage of neurons, and as well as enduring hypercortisolemia. Stress, monoaminergic systems, and limbic system are all together are involved in exert an effect on depression. So it's a pathogenetic hypothesis, complex interaction between genetic vulnerability, maybe because we are talking about major depression, bipolar disorder, so genetic vulnerability, and environmental factors. In the environmental factors, we can put inside, within this, we can find stress, the caregiver, trauma, whatever. Really specific, really generic. And now I'm interested in talking about overlapping differences and drugs. Overlapping, just one slide for each of this. Feature one, overlapping. We said that the primary manifestation of depression is mood disorder. At the same time, some features of depressive disorder overlap those of the anxiety disorder. This is not only a new category, anxiety and depressive disorder. It's not only a new category. It's a new category because they studied this. So anxiety disorder, including in this big category, the overlapping between depression and anxiety disorder means panic disorder, phobias, generalized anxiety, social anxiety, post-traumatic stress disorder. We cannot say post-traumatic stress disorder belongs to the anxiety system or depressive system, both. And obsessive compulsive disorder, because they have the same circuit. Depressive mood also may be associated with psychosis. Think of delusional disorder. this perception disorder in psychosis. And usually we find depression and psychosis, they go together. Differences, not so clear to understand the differences sometimes between the depression and anxiety and stress and borderline personality. First of all, for all of us as psychoanalysts, clinical depression must be distinguished from normal grief. Normal grief doesn't mean depression. Sadness. Sadness is normal sometimes, okay? In front of separation distress, maybe I'm sad. Okay, sadness. Disappointment, life disappointment. Dysphoria or demoralization for maybe chronic illness. So this is not depression. And major depressive disorder, you can find the symptom of major depressive disorder if you think about this. This is not depression. When you find intense sadness, despair, mental slowing and loss of concentration, pessimistic worry is not concern. The concern involves the anxiety circuits. This is a pessimistic worry, lack of pleasure, self-deprecation, and many other. And sometimes in major depression, we find physical changes also occur, like insomnia or hypersomnia, like losing weight or taking weight, like more energy in mania, and losing a libido, disruption of the normal circadian rhythm. This is the involvement of the body. Antidepressant drugs. What is beyond this window? Okay. The most sold neuro, psycho, medicine globally include widely prescribed antidepressant and antipsychotic. The most sold antipsychotic is sertraline, Zoloft, serotoninergic reuptake, the most, at the top in the world. Major affective disorder, then we find, I see here, I cannot see there, the antipsychotic, the anti-anxiety, the anti-manic, the antidepressant drugs, almost all the drugs, they affect cortical, limbic, hypothalamic, brainstem mechanism, and that are fundamental importance in the regulation of arousal, consciousness, affect, autonomic function. So, can we say this maybe the antidepressants act in a specific way, just because we give a sertraline, we give a serotoninergic, or this is a not specific way they act? Another important overlapping, stress and depression. This morning we talked about trauma and stress. Now we talk about stress and depression. I think Mark in the afternoon will talk about this schema. This was introduced to us 10 years ago, and when the seeking system shut down after a period of despair, we experience depression. But maybe in the afternoon Mark talk about the emotional system. I would like to talk about the role of stress in depression. Okay. Mood, we know, this is obvious, okay? We know disorders are often triggered by events of life stress. Sometimes in the colloquium, when we talk in the dialogue with the patients, we find triggers for depression. But we need to think about, is this depression or is this sadness, mourning, and so on? Okay, mood disorders are often triggered by events of life stress. Stress activates the hypothalamic pituitary adrenal axis, HPA. Stress causes damage, same mechanism of depression, reduction in the dendritic branching in hippocampus, and not all in hippocampus, and stress inhibits all the neurogenesis in hippocampus. And stress obviously reduces transcription for some neurotrophin for the brain system. Stress and hippocampus again. Again, normal. This is a normal A3 and first layer of hippocampus. In stress, this is the synapse and dendrites. We can find this reduction. And they say antidepressant maybe ameliorate, increase this neurogenesis. It's the same. Here, this is the dentate gyrus, this is the CI3 pyramidal cells, normal, and stress. So the stress has a direct impact on depression, or at least on the phenomenology of depression, okay, on the behavior of depressed patients. Another overlapping and differences. Take a look at this and remember this. You are not maybe a medical doctor, but you need to remember this, because this is anxiety. This is stress. This is not depression. Different mechanism. This is the GABAergic system. The GABAergic system is, we have a GABA receptor in all our brains. Above all, the most part of them are in hippocampus, amygdala, and many others. So the GABA receptor control the chlorine channel is exert a strong effect on anxiety because activate this circuit. Oh, this circuit. But not only this. So there is this is a mark. And all this circuit activate the central nucleus of amygdalas. Hippocampus, amygdala, hippocampus means emotion, learning, cognition. So this is the anxiety circuit. This is etiopathogenesis of depression. Anxiety circuits, GABA receptor, GABAergic system. Depression. Reduced the transport of catecholamine into presynaptic terminal, all the catecholamine. Reduced the bufferability of synaptic vesicles. Fluctuation of catecholamine concentration in the cleft, synaptic cleft. Increase maybe of dopamine or hypersensitive of dopamine in the mesolimbic system, above all in case of bipolar disorder, but sometimes, and not only sometimes, deficit in norepinephrine and dopamine. This is not a balanced circuit. Depression and anxiety, they share this same mechanism, deficit in norepinephrine and dopamine and the serotonin. Okay, and at the end, you find deficit of serotonin. This is deficit of serotonin. So depression involves norepinephrine, dopamine, serotonin. The serotonin unbalancement is just one of the core of depression, the mechanism. But we give serotoninergic drugs, okay? Antidepressant. Just, I don't want you to see this. I just want to show you, remember what I said. Are we sure the complexity of the mind is more than the complexity of neurobiology? Take a look at this. This is the norepinephrine presynaptic and postsynaptic neurons. Serotonin, presynaptic and postsynaptic neurons, just two neurons. If you take a look inside of this is norepinephrine, but norepinephrine is controlled by serotonin, and is controlled by inositol circuit, means lithium. And the same, serotonin system is controlled by, I cannot see from here today, it's controlled by norepinephrine also, and is controlled by all the circuits of the inositol circuits, lithium, and there is no chance for the GABAergic systems to control this system. This is a big difference when we give drugs for depression. We cannot give an anxiolytic. We cannot use benzodiazepine for depression. This is just to say. Take a look at this, the same, presynaptic and postsynaptic neurons. Serotonin, okay, serotonin, the oldest class of antidepressant, IMAO, okay, monoamine oxidase, tricyclic antidepressant, tricyclic antidepressant, lithium, serotoninergic here, the transportation of serotonin. That means, are we sure they act in a specific way? So, above all, if we consider this, the modulation between this circuit, norepinephrine, and between serotonin. They have a reciprocal control. Today, but the most sold antidepressants in the world are the SSRI for the reuptake of serotonin. But a multitude of brain functions are influenced by serotonin, including sleep, cognition, sensory perception, motor activity, temperature regulation. This morning we talked about temperature, mood, appetite, sexual behavior, and so on. So we cannot say the depression, the involvement of serotonin is pathognomonic of depression. And usually we say the raphe-nuclei is the system plane of serotoninergic receptor. But the raphe is the truth, it's not the only one. But the raphe-nuclei is under the control of the locus ceruleus. Locus ceruleus is norepinephrine, release norepinephrine. Why this reciprocal control is really important? I would like to stress just this, sleep, wake, rhythm. The locus ceruleus release norepinephrine 24 hours for 24 hours, except in a moment, during the second phase of the non-REM sleep. All in this moment, for few, I don't know if seconds or minutes, for few moments, the locus ceruleus stops producing norepinephrine, all in this moment. And in this moment, and all in this moment, the hippocampus and the cortex, they starting a dialogue. And after this dialogue, we start dreaming. So this is under the control of serotonin and locus ceruleus and the norepinephrine system. But in order to control this system, obviously, we need now today different drugs. So they can act on norepinephrine system and the serotoninergic system. But here there is a big absent. In this picture, in my slides, there is a big absent. The big absent is the dopamine, okay? So, in any case, the GABA and the dopamine, you can see there, dopamine. Dopamine is maybe Mark can talk better than me about this. Dopamine involves a lot of specific circuits in the brain. It's different from serotonin, norepinephrine, acetylcholine. I don't want to talk about this, but it's totally different. Dopamine is more specific than serotonin, acetylcholine, and norepinephrine, or at least the circuit involved in dopamine. For this reason, we study a lot the dopaminergic system. We need dopamine. And nuclear accumbens is under the control of tegmental area, and they control the glutamate. That means dopamine and GABA system, anxiety, go together. Dopamine system, the big absent. Because the dopamine system is another circuit. It's involved also in depression. Think about Parkinson's disease and depression. They go hand to hand, okay? Because the repletion of dopamine. So this is the dopaminergic system, and the dopaminergic system is really specific because release opioid, because release endorphin, because act on prefrontal cortex or the frontal cortex. The mesolimbic system is different from the mesolimbic system and the cortex altogether. This is the dopaminergic system, and it's involved more in psychosis and other. So today, targets multiple receptor is a clinical, is really relevant in addiction to SERT inhibition. We cannot talk about only about serotonin and serotoninergic and SSRI when we talk about depression. Because the general medical doctor today, if you go there and you say, I'm depressed, they give you the serotoninergic. So at least today, I want you to understand this. The serotoninergic, the SSRI, maybe doesn't cure the depression. The system is more complex than serotonin involved, the involvement of serotonin. Serotonin, norepinephrine, dopamine interact via complex inhibitory, sometimes excitatory, okay, feedback in the central nervous system. And they act on motivation, reward, appetite, impulse, mood cognition, positive thinking, energy, interest, anxiety, depression, all together. The dopaminergic system, norepinephrine, and the serotonin, they act all together for healthy system, to be healthy, we say. So, to conclude. Today, we, in case of depression, usually we start with different drugs from SSRI. We start giving these new drugs, new medicine. When changing the dosage, just changing the dosage, we change the norepinephrine system or the serotonin system. So we can control the release of norepinephrine sometimes, we can, in case of some symptoms, or we can control the serotoninergic system. And today, we have drugs to control all the three monoaminergic systems, dopamine, serotonin, and the norepinephrine. But today, go back to us. We don't talk in our office. Sometimes I meet a lot of depression, mania, and I treat by drugs them. But today we meet, above all, we meet depressivity. Depressivity is for the young people today. I don't know how to understand depressivity. Depressivity is not depression. It's not the reaction to depression. It's like the system. Do you remember my normal mood, zero normal mood? They don't have zero normal mood. Usually they are under this zero, and they don't want to stay under this zero. This is depressivity. And this is why addiction are so strong around the world. Depressivity, the ultra rapid cyclers, drug addiction, okay? Not only addiction, substance addiction, at the same time gambling, or internet addiction, or pornography addiction, ultra rapid cyclers. And the people who cannot recognize their emotional affective status. And in the 10 years ago, we called this anhedonia. Now we call this emotional affective status not recognized. Stop.